for an opportunity to speak to something that's very close to my heart and part of my clinical practice here in Edinburgh. Now we'll see if Zoom's going to behave itself. So, just to start off, I do have some disclosures. I'm a clinical academic, so I have had some research funding from various sources, majority from factors such as the government. I'm a consultant gynaecologist as well as working for the University of Edinburgh. And as part of my specialty training, I did the advanced specialty training modules in both advanced laparoscopy for excision of bediated disease, which is then advanced laparoscopy for and so it's typically for complex endometriosis. Alongside that, also did specific menopause training. And I am based in Edinburgh at a centre called Expect. Now, this is a collaboration between the University of Edinburgh and NHS Lothian. So within NHS Lothian, we have a tertiary endometriosis referral centre. So this is a BSG Centre for Management of Complex Endometriosis, and we cover the whole of South East Scotland for that. I also work at the Chalmers Menopause Centre for NHS Lothian, which gives contribution for some of our endometriosis care. But also I have a role within the University of Edinburgh as a clinical academic. So within Expect, we have research spanning from discovery scientists, data scientists, as well as clinical trials, which is where I tend to have more of a leadership role within some of our different both surgical and medical trials for trying to improve care for endometriosis patients. But why I became interested, I came to menopause being in someone who cared for patients with endometriosis and pelvic pain. And it was really reflecting that a lot of our patients who we'd done surgery for, particularly complex endometriosis, when we saw them for our follow-up, their pain was often very much improved, but actually they were suffering the consequences of menopause. And I think I certainly felt that I didn't have an adequate knowledge base to be able to effectively address those symptoms. Similarly, a lot of my pain patients, both those with and without endometriosis, as well as patients affected by abnormal uterine bleeding, often was using medications to put them into a reversible medical menopause. And again, some of those patients had to stop a treatment that was effective for either their pain or bleeding because they were troubled with menopause symptoms. And so that's why I went off and did additional training in menopause. So in terms of what we're going to cover this evening, first I want to talk a little bit about menopause generally. And then I want to talk a little bit about how that interacts with endometriosis, and then broadly speaking, our approach to the care of menopause symptoms in patients affected by endometriosis. So just to start off with a few little definitions. So medically speaking, we define menopause as the day following 12 consecutive months without a period. But I think more generally, we use the menopause term to describe this time in life when you're experiencing symptoms relative to fluctuating and ultimately falling hormone levels. And over that time, you will eventually stop having monthly periods. Now, the average age in this country of menopause is 51. But some patients do undergo menopause at a much earlier age. And when this happens in the absence of factors such as surgical removal of the ovaries, which is often called a surgical menopause, it's called premature ovarian insufficiency or premature menopause. Now, some of the stages of menopause, we don't go from having perfectly working ovaries to being menopausal. And often patients, often there's this phase before the actual onset of the menopause called perimenopause, which is when the hormone levels are fluctuating a lot more, and patients often start to experience those menopausal symptoms. And then postmenopause is after that 12 months of absence of periods. So just in terms of what this means in terms of hormones. So before people undergo the menopause, when they're going through their natural menstrual cycles, we have fluctuations of the two main ovarian hormones of estrogen and progesterone. Estrogen, the dominant hormone, is called estradiol. We see that increase just up in the lead up to ovulation, then it drops and then rises again in the second half of the cycle. And the second half of the cycle is when progesterone becomes the much more dominant hormone. And this has an impact on the changing of the endometrium, shown here, the lining of the womb. And it's also potentially leading up to ovulation, preparing the lining of the womb to accept a pregnancy. And then in the absence of implantation of an embryo, then there's shedding of the endometrium with following loss with progesterone. Now, as the store of eggs in the ovaries depletes the levels of these associated hormones, estrogen, progesterone, the levels become much more erratic. So now women have hormone receptors all over their body. So when these hormone levels start to fluctuate a lot more in the perimenopause, the body has to adjust. And this potentially leads to a range and combination of physical, psychological, and cognitive symptoms for some people. Now, it's not just all about estrogen, although this is the main driver for a lot of the symptoms, but there's also progesterone can play a role in some of the symptoms we've experienced. Now, progesterone's main role in the cycle is to help maintain a potential early pregnancy. But when this hormone starts to deplete, which can happen quite regularly, then sleep can become disruptive. Now, while progesterone levels continue to fall, then that estrogen levels become more and more fluctuant, and this can leave that real sort of fluctuation in menopause symptoms. Now, those symptoms, the most classical ones is hot flushes, but there are many, many symptoms associated with the menopause. And I think alongside these hot flushes, night sweats, which we often refer to as vasomotor symptoms, we're very conscious of the impact on cognitive symptoms. And I think low mood, anxiety, poor concentration and forgetfulness are often very prominent features and can really impact upon individuals' quality of life. There's a collection of symptoms which are known as the urogenital symptoms. So this is a reflection of the decreasing levels of estrogen and how they affect the genital tract. So we see a lot of vaginal increases in vaginal dryness and a tendency to more frequency bladder instability and urinary tract infections. Skin changes can be quite prominent, and that includes sort of skin dryness and also changes in hair. Often individuals slight loss of hair. And there's also can be an impact on the musculoskeletal symptoms, so both particularly joint and muscle aches. And then there's also the impact on libido. And so often patients around the time of or individuals around the time of menopause will have a reduced interest in sex, although libido in itself is a complicated thing and not purely related to hormones. But I think rather like endometriosis, the symptoms of menopause can impact upon every facet of life, be it work, social lives, intimate relationships, as well as impact on sort of the wider family and colleagues. There's also the negative health consequences of the menopause. So this loss of estrogen increases rates of osteoporosis developments. That's a thinning of the bones. And there's increased vulnerability to cardiovascular disease and stroke. And it's why women compared to the men in their sort of 30s and 40s, men have much higher rates of cardiovascular events. That's predominantly due to the protective effects of estrogen. But as they go through the menopause, then they start to catch up with men. So in the general population, how do we manage menopause? Well, I think first and foremost, we always will consider the role of diet and lifestyle modification, because this is one of those opportunities for us as a healthcare provider to try and improve factors related to overall health, particularly recognizing the menopause as a time of change and then that increasing vulnerability to cardiovascular disease. So factors such as smoking cessation, weight loss, alcohol reduction, increasing exercise are very important for generalized health promotion, but they also can have positive impact on menopausal symptoms themselves. The other main strands of menopause management include hormone replacement therapy, which we're going to talk about quite a lot over the next 20 minutes or so. There's also the role of cognitive behavioral therapy. And then for not so much as a first-line treatment, but for as second-line treatments or for those in whom HRT is not appropriate, there are some non-hormonal medical options that we can offer. I think it's always important that we can address any urogenital symptoms. That's usually the topical use of estrogens. And then for libido management, there's also a role for testosterone as well as the sort of the standard HRT, which is estrogen, progesterone. The NICE guidelines for management of menopause were published in 2015, but there is a newer version which is currently under review. So a draft version of this has been released last week, and that is out for review at the moment. We hope to have that sign off in the early of next year. And the main changes in the new draft guideline is that recognizing the increasing evidence for CBT, it still will be that for management of vasomotor symptoms and low mood due to menopause, HRT would be considered rather than antidepressants, but it's using CBT as an adjunct. And there's also been quite helpful increasing evidence for CBT for its role in management of vasomotor symptoms and sleep as well. The other thing that I think is quite helpful in this new iteration of the guideline is that there's increasing evidence about the risks and benefits of HRT on factors such as cardiovascular disease, risk of breast cancer, as well as some of the new data that's arising concerning the relationship between HRT and dementia. But it still maintains within the NHS, within the NICE guidelines, that for vasomotor symptoms such as flushes and sweats, that HRT should be offered after full consideration of the risks and benefits. And it's been shown to be the most effective treatment with the minimal risk. Now, the type of HRT is determined very much by the individuals, including factors such as whether or not they've had a hysterectomy, whether or not they're perimenopausal or they've moved into that postmenopausal state, as well as encompassing factors such as past medical history and family history, other medications used. And I think key at the centre of this is also their individual preferences and having a holistic approach. Alongside, and there are lots of parallels between menopause management and I think endometriosis management. I think part of that is the importance of, where self-management strategies can be helpful. And I think particularly for flushes, so vasomotor type symptoms, there are some of those factors that we know can be triggers, and particularly things like alcohol, caffeine, hot drinks, spicy foods. And so factors that allow patients to, I keep saying patients, menopause is something that, all those assigned female at birth and will go through at some point in their life. So patients is the wrong word to use. But factors that individuals can use are things such as layering of clothing, thinking about their bedding. Exercise can be helpful for vasomotor symptoms, and also weight loss can also, so having the weight within the healthy range can be also improve symptom control. And we've talked a little about some of the CBT and mindfulness techniques. And some of the resources we suggest locally are shown here. There clearly are many different resources out there, but there's some of the ones that we routinely would suggest within our clinic. And I think one of the places I direct people to most frequently is the Women's Health Concern website. So this is the patient-facing arm of the British Menopause Society, and they've got lots of different fact sheets for patients seeking help about range of factors from understanding the menopause better, the roles and pros and cons of HRT, as well as some of the other strategies for managing symptoms, as well as factors such as management of menopause and in the workplace, and how to try and optimize maintaining individuals within the workplace. But a lot of what we do, and as I said, the recommendations and NICE guidelines around offering HRT to manage menopause symptoms. Now, I am very happy to give more details about specific types of estrogen and progesterone after the main talk. But the kind of main factor of HRT is giving people estrogen only, and this is for patients that do not have a uterus anymore and do not have significant endometriosis. I'm going to come back to that. But for the majority of patients, particularly those who've got, and everyone who's got a uterus, we will tend to give combined HRT. So that's HRT that contains estrogen and progesterone, and it's predominantly the estrogen to manage symptoms, and the progesterone is there to help protect the lining of the womb. Because if we just gave estrogen alone, someone who still had a uterus, that would cause proliferation, so increased turnover of the cells within the lining of the womb, and ultimately that can lead to precancerous and then malignant change within the endometrium. So that's why in anyone who's got a uterus, we would always give progesterone to protect that endometrium. How we give the progesterone can be variable. So we can either give it all the time alongside the estrogen, or we can give it in what we call a sequential approach. So that's the half the time they get estrogen, and then the other half the time they get estrogen and progesterone. We can give HRT in a series of different ways. So we can give it as a tablet. We can give it through the skin. That's called transdermal estrogen, and that's typically with an adhesive patch. We can also give it as a gel or a spray. Less frequently, estrogen can be given as an implant. I have to say something in our service locally, we don't use that. And there's also the role of local estrogen to manage urogenital symptoms. That's typically as a pessary or a cream for vagina. In terms of how we give the progesterone, we can give that as in tablet form, and either as a separate tablet or combined with an estrogen tablet. We can give a combined patch with estrogen progesterone, and we can also give it through an intrauterine system containing lumegestrel. So that'd be sort of a common brand name of that would be the Marina coil or Levocet coil. And sometimes splitting the estrogen and progesterone can be quite a helpful thing to do, because it allows us to titrate up the estrogen level whilst giving the appropriate progesterone protection. Now, like all medications, there's side effects. I think typical side effects are often usually around the time of starting treatment or having a dose change, and breast tenderness, leg cramps, nausea, bloating, and irritability have all been reported. I think the more common factor for those who are particularly starting HRT around the perimenopause is unscheduled bleeding. And then separate to side effects is the risk of HRT, and the main ones of these are surrounding arterial and venous thrombosis, risk of breast cancer, and the impact of dementia on those typically starting HRT above the age of 65 or more. Now, as I said, I'm happy to talk about the specific types of estrogen progesterone after the main talk, but one of the places I do often direct patients to is the Women's Health Concern website. Now, to go back to this clot risk, I think one of the key factors is that we know that tablet form of estrogen definitely does increase the clot risk. But the evidence suggests that HRT that is transdermal HRT, so that's the estrogen through the skin, does not appear to increase the clot risk in a general population. So I have to say we have extrapolated this, that if patients who've got a higher, that have had previous clots in the past, so things like P and DVT, we sometimes would consider this a transdermal as a more safe approach. But within our general population, we certainly would recommend transdermal estradiol anyone who's got other risk factors for thrombotic events. So these things such as increased BMI, high blood pressure, I'd also include a family history of cardiovascular disease. But the other factor that I tend to find most prevalent amongst my endometriosis patients is that often they've got a background of migraine with aura, and use of oral estrogen can slightly increase the risk of stroke in that population. So I would always use a transdermal preparation of estrogen in that group. And again, part of HRT care is about individualizing it and empowering patients' individual choices, and that many of our patients will want to minimize the clot risk, even if they don't themselves have any particular risk factors. So again, the transdermal estrogen approach would be the most appropriate. So sort of key factors to take just from this first section. So in terms of what the menopause is, reduced ovarian function, which lowers the levels of estradiol and then results in a menopause symptom. So I think it clearly is a bit more complicated rather than just related to estrogen alone. Using HRT can help with some of those symptoms, and it also can offset some of those risks, that increased risk of cardiovascular disease and osteoporosis. We do need to be careful about the use of unopposed estrogen because of the impact on the lining of the womb, which is why we use a progesterone. HRT can be very effective for symptoms, but it does have side effects and health effects. And particularly, most common side effect patient report is erratic bleeding. And we also need to be conscious of contraception. So I now want to move on to talking a little bit about endometriosis. I'm about to show you a picture of some endometriosis taken from surgery. So if people don't like surgical images, then now's probably the moment to look away. But we know that everyone here will be well aware that endometriosis is common. 1 in 10 women and those assigned female at birth. It is associated with a myriad of different symptoms. The hallmark of it is pelvic pain, but also factors such as impact on bowel, bladder function, fatigue, heavy periods, the impact it can then have on associated risk as depression, anxiety, as well as the impact on subfertility. The mainstays of our treatment at the moment is medical treatment, typically with hormonal suppression or surgery to remove the disease. But we know that for many, this either won't be effective or will only have short-term relief. So there's a real unmet need, aside from anything we're talking about menopause, to having more effective treatments to manage and offer patients with endometriosis. But what's the relationship between endometriosis and the menopause? So endometriosis lesions contain both receptors for estrogen and progesterone. So this is a slide of some endometriosis lesions. It's been stained here for estrogen receptors with little brown spots here. You can see lots of those expressed there. And then also the brown spots here are looking for the progesterone receptor. And this is really, we know that endometriosis tends to be driven by estrogen, whereas progesterone tends to have a more protective effect upon it. And this is really the rationale for a lot of the hormonal treatments that we use. It's also why often patients, when they're rendered menopausal, be that a natural menopause, medical menopause, or because of loss of the ovaries, that they have an improvement of their symptoms. Although it's not that we're recommending removal of the ovaries per se as a treatment for endometriosis. So these types of menopause, so natural menopause, so the ovaries, they've had loss of the number of eggs, and so their function has reduced, then finally stopped in terms of estrogen and progesterone production, as we've already discussed. But we take advantage of this with some of our medical treatments. And I think the main ones are the medically induced menopauses, that are relevant. So these are a class of drugs known as predominantly the GnRH agonists and then also the antagonists. Now, the agonists are the mainstays of what we use in the UK, and these include drugs such as Prostav and Zoladex and Decapeptyl, which are given as an injection, or you can have an inhaled GnRH agonist such as Buserelin and Naferolin. In the ESHRA guidelines, which many of you might be aware of, that were published last year in Europe, they also recommend the GnRH antagonists as second-line treatment for endometriosis. So these are a tablet form, which also basically induce the same menopausal type state. These are not yet available in the UK. One of them, called Relugolix, is available in the UK for treatment of fibroids, but it's not yet licensed in the UK for treatment of endometriosis. But there are various agents within this class which have all had very large clinical trials conducted in endometriosis and do show a lot of promise. But both of these groups will render people in a reversible menopausal state, which is good for their endometriosis symptoms typically, but not necessarily all that good in terms of cardiovascular bone health, and also will be associated with menopausal symptoms. I think the other cause of menopause that's very relevant within endometriosis is that as part of treatment, sometimes we do remove both ovaries. That's known as surgical menopause. But also patients who've got ovarian endometriosis, repeated surgery on the ovaries can cause a loss of ovarian function, which can some patients ultimately result in a premature menopause. And we know certainly the risk of that goes up if you're operating on both ovaries, and particularly if it's a repeated surgery to our ovaries. So these would be the sort of main three groups of patients that I would see in my clinic, which is meant to do both the management of the menopause as well as managing their endometriosis at the same time. So when we consider the management of these patients, and I'm going to talk first about natural menopause and medically induced menopause before moving on about some of the specific considerations regarding surgically induced menopause and endometriosis patients. So whenever I am seeing a patient, again, there's this opportunity for long-term health promotion and interventions to try and improve subsequent health. So always those lifestyle modifications, which is also going to try and reduce the potential negative health consequences of being in a menopausal state. So that's weight reduction, stopping smoking, minimizing alcohol, which, as I've outlined previously, can help with symptoms as well as those beneficial long-term health consequences. And then my next job is to try and minimize risk. So that's both about minimizing the risks of being in a medically induced menopause. So that's the menopausal risks on cardiovascular and bone health. So aiming to protect those. And then further try and reduce the risk if we're going to use HRT to address these cardiovascular and bone protection factors, minimizing by our choice of HRT, that we're going to reduce the risk to that individual. So I typically, in these patients, will use a continuously combined regime. Now, certainly in our medically induced menopause patients, they don't have their own sort of fluctuations in the same way of their own hormones, so they often tend to have much better bleeding control. So a continuous regime is very appropriate. Now, someone's naturally coming to the end, coming through the menopause. Often their own hormones are very variable. And if someone didn't have a history of endometriosis, I often typically in someone who's perimenopausal, put them on a sequential regime. So this is when they have estrogen all the time, which is to manage the symptoms, but progesterone only part of the time. And the rationale for that is it tends to give better bleeding control. The problem with endometriosis patients is if you give them a sequential regime, part of the month they're getting unopposed estrogen, so just estrogen. As we've discussed already, estrogen tends to drive endometriosis. So I often find that patients with endometriosis, if they go on a sequential regime, they often have they can have an exacerbation of some of their endometriosis symptoms. So I will often either have them on a continuous combined regime or use, and often the regime that I find is most effective is using a levonorgestrel intrauterine system, such as a Mirena, to give that continuous estrogen, progesterone, which tends to give much better bleeding control. The other option is to have them on a sequential regime, but then also give them an additional progesterone to try and maintain that endometriosis suppression. I think one of the factors we need to consider in patients who are in both these medical menopause and natural menopause groups is that sometimes they're often women that have a contraceptive need. Now, these whilst the chance of pregnancy in late 40s, early 50s is very low, it's not entirely negligible. So we do have to address that contraception need if required. And for those who are in a medically induced menopause, these agents are not licensed as a contraception. So for patients not planning pregnancy, we would normally recommend a form of contraception alongside that. I think one of the other important factors is to ensure that we're managing urogenital symptoms. So for these patients, I will typically have them on HRT or offer them HRT. And systemic HRT is often very good for the majority of their symptoms, but they may have ongoing urogenital symptoms, so that's particularly vaginal dryness. So in that case, giving additional vaginal estrogen can be very helpful, or indeed for patients who don't want to have systemic HRT but are troubled by vaginal symptoms, in which case they can have local estrogen on its own without systemic HRT. I think use of lubricants is very important. And then for some patients, if they've got ongoing issues with low libido, despite having adequately replaced their estrogen, we will consider a trial of testosterone. Now, there's a lot out there in the media about testosterone, and I think there's been a huge amount generally about the menopause, which I think has been really, really positive. It has empowered individuals to seek help and be given better help than perhaps they were having in the past. But I think one of the difficult things in this space is that a lot of the dialogue around testosterone and the evidence for testosterone is in the context of menopause is only at present to support improving libido. So there isn't evidence for any other symptoms being improved by testosterone. There aren't any licensed preparations of testosterone in this country, so we tend to use male preparations in an unlicensed fashion in this group. And there's a few factors around side effects and monitoring of use, but certainly in someone who's had appropriate management of appropriate HRT, who's still suffering from low libido in the context of the menopause, then I would often use testosterone in this group. And I think it's all about individualizing it for those patients. So patients will come with different risk factors for HRT, and they will also come with different symptoms. So I think it's all about having a patient-centered approach, and there's no one size that fits all. I think the other important factor to talk about is surgically induced menopause. And part of this is because that decision to have to undergo an early menopause through the route of surgery, I think needs to be very carefully considered by an individual and sort of weighing up the pros and cons. And I'm also very conscious that during this counselling, some of the data we have to support informed decision making isn't necessarily all that good quality or is extrapolated from more generalized populations, which I think makes it very hard for individuals to make a decision. But these are kind of the broad themes that I think it's very important to be discussed. So firstly, if you undergo an early menopause without any consideration of, or without any add-back HRT, there is the impacts of an early menopause on increased risk of cardiovascular disease and increased risk of osteoporosis, as well as the patient is likely to develop menopausal symptoms. And I think often with a surgical menopause, because you have that very abrupt change in hormone levels, that transition can sometimes be very debilitating and severe. And for some patients, even with the use of HRT, we aren't necessarily able to fully manage all menopausal symptoms. I think there's also it's particularly this impact of cardiovascular disease. Now, this is a large study of over 200,000 patients in Canada who had their ovaries removed for non-cancer indications. And this is really helpful at giving us some more data about the relative impact of cardiovascular disease of losing your ovaries prior to the age of natural menopause. And this study found that the increase in all cause of death for patients who are under the age of 40 or 45 was increased by 31%. So that's quite a big increase. I think that equally also needs to be taken in the context. So relative risk is different to an absolute risk. So the chances of someone dying who had their ovaries moved under the age of 45 is actually very low over the next 20 years. And so that absolute increase in risk is only in the realm of probably around just over 1%. So it's the overall increase in chance and death is actually very small. But because of that, there is that increase compared to someone who's not going to. I think it's really important that is discussed prior to undergoing something that's an irrevocable step in their treatment. So that's why I am very keen to ensure that our patients who are having their ovaries removed at an earlier age are offered HRT to try and reduce this risk of impact on cardiovascular death. The reason why this has to be weighed up against the pros and cons of leaving the ovaries in is that we know that of patients who have their ovaries retained after surgery, that we know they've got a higher chance of presenting with recurrent pain and a much higher chance of a reoperation. And particularly if someone's had a hysterectomy but had their ovaries conserved, we know that that surgical procedure is actually technically much more difficult, removing ovaries, when a previous hysterectomy has been performed. So I think it's about careful weighing this up, as well as individualizing that patient's pros and cons and risks of having an early menopause and their options for HRT. And clearly that will differ in someone who's perhaps got a very strong family history of, say, breast cancer or have a clotting disorder compared to someone who doesn't have those factors. So in terms of managing these symptoms after surgery, it's about minimizing the risks of early menopause, as well as also optimizing quality of life. And I think, for this, particularly removing ovaries, if we're doing this to try and improve as part of surgical management of endometriosis to improve their quality of life, if we help with their quality of life impact from pain, but then give them debilitating menopause symptoms, one could argue that the impact on overall symptoms is actually your overall quality of life perhaps might not necessarily be considered a sufficient benefit to have undergone that procedure. And also we want to minimize the individual risks. So that's optimizing lifestyle factors, the choice of HRT regimes that we use, and typically this will be around the use of transdermal estrogen to minimize clot risk, as well as considering what progesterone we're going to use. And certainly going back to that question of oral HRT, there are some patients who actually will use the combined oral contraceptive if that's appropriate for them in terms of risk profile. And actually, there's quite a lot of uncertainty, particularly in patients under the age of 40, whether or not standard HRT or the combined oral contraceptive, which makes patients happier and has best impact on bone health. And so for any of you who are on this call who are being considered for removal of ovaries under the age of 40, you might be asked about this trial, which is comparing the combined oral contraceptive versus HRT following a premature menopause. Other factors to consider in terms of instigating HRT: timing following surgery, just because HRT does slightly increase clot risk, and if you've had a long operation, your risk of a venous thrombosis will be increased as well. So often we delay it by around about a month. But again, it's individualized, and perhaps those who've got less risk factors and are having transdermal HRT, we can shorten that time period after surgery. There's also consideration of the type of progesterone, and perhaps there are pros and cons of different types of progesterone in terms of breast safety and clot risk. And I think one of the big debates is the question of whether or not patients, once they've had a hysterectomy, as well as the removal of their ovaries, the pros and cons of combined HRT, so that's estrogen progesterone versus estrogen only. And why this is relevant is that there's a good body of data suggesting that in terms of a breast cancer risk, estrogen-only HRT does appear to be a little bit safer. So in patients who've had a hysterectomy without a history of endometriosis, we would use estrogen-only HRT and recognise that that is certainly better for their risk of breast cancer. However, one of the challenges in patients with endometriosis is that even once we've done a hysterectomy and removed the ovaries and removed all the visible endometriosis, there's a concern that there might be microscopic deposit of endometriosis. And so if you gave people estrogen-only HRT, that could potentially stimulate these microscopic fragments, and therefore that would, first of all, cause a recurrence of symptoms, but also there's that same potential risk of giving of unopposed estrogen on an endometriosis lesion, which is very similar to the endometrium, so the lining of the womb. And then certainly we know in the lining of the womb, if you gave people unopposed estrogen, that would increase the risk of potential risk of malignant conversion. And certainly there have been some case reports of patients who've had a hysterectomy but had endometriosis, who had estrogen-only HRT, who then underwent malignant transformation of those lesions. Now that risk overall is low, but it certainly has been reported. And so certainly from the ESHRA guidelines, they would strongly recommend that for anyone who's had a hysterectomy and removal of ovaries in the context of endometriosis should have combined HRT. Now, the British Menopause Society I think, takes a more holistic approach in terms of considering it's not just the impact on any potential microscopic endometriosis, but also there is that differing risk profile for breast cancer. And so they take the view in those that have had, all visible endometriosis removed, that whilst they recommend a combined HRT initially, after a couple of years or several years, they're slightly non-specific of the exact time period, then the consideration can be given as to whether or not a trial of switch to estrogen-only HRT. But again, I think that has to be a very individualized decision, and again, taking in pros and cons and background breast cancer risk in that individual. I think one of the other factors that's very important is managing urogenital symptoms, and I often will use quite a lot of topical estrogen in my post-pelvic clearance patients. But sexual function is not all just about estrogen within the vagina, and it's also not, libido is not all related to testosterone. So I think it's important to address factors such as pelvic floor tension, making sure additional adequate use of vaginal lubricants during intercourse. But I also do in these patients, once they've had optimization of their estrogen, if there's ongoing issues with low libido, again, I would consider a trial of testosterone in that group. And again, to redirect you back to the women's health concern, they've got a specific information sheet for patients who are having induced menopause in the context of endometriosis, which you might find a useful resource. So in terms of some other resources apart from the women's health concern and the British menopause, NHS Inform in Scotland has got lots of really helpful web pages, both about endometriosis and the menopause. I think for those with premature menopause, there's the DAISY network, as well as menopause matches. And I think one of the big challenges for individuals going through the menopause, be it through natural menopause or an induced menopause as part of their endometriosis treatment, is that impact that they have in the workplace. And both Wellbeing of Women and I know Endometriosis UK are working on this too, of strategies to try and help you navigate management of symptoms within the workplace, and also some resources to direct line managers too. And for all your general endometriosis queries, again, I would direct you to Endometriosis UK. So just to finish up, relationship between endometriosis and the menopause is complex, both in that treatment for endometriosis can induce menopause, but also menopause can change endometriosis symptoms, and often that is for the better. But it does mean that we need to consider the impact on endometriosis when we're managing the menopause, particularly in the use of HRT. I think it is very important in patients who are having an early menopause to have the impact and consequences of this to be carefully discussed to inform decision making. But I would say that for most of our patients that we can effectively control their symptoms. But it is important to acknowledge this impact both on the menopause as well as the endometriosis itself. I think one of the challenges we have is about the evidence base with which we use to counsel patients, but I think also we always need to consider an individualised approach to care. And on that note, I'm just going to finish. Thank all the team here in Edinburgh, as well as those that have supported our research. And I'm happy to take any questions.
Brilliant. Thank you so much for that. I will start reading out the questions. Okay. So first, I am 43 and going through early menopause, which was brought on after the removal of my right ovary and fallopian tube due to endometriosis. I'm currently on HRT patches, which have relieved so many symptoms, but I am now plagued with profuse sweating. Is there anything natural I could try to help with this embarrassing problem? Any advice would be greatly appreciated.
So I suppose firstly, just to reiterate what you said at the beginning, Shafi, so I can't give individual healthcare advice. I would say for the symptom of sweating, first of all, it's about ensuring that as an appropriate, if an individual is using HRT, then ensuring that dose has been optimized. Then the other things I think are always important to consider triggers. And clothing can also be quite helpful to offset the impact of sweating. One treatment that we do use, particularly for wet sweats, is a drug called oxybutylin, which is a licensed treatment for an overactive bladder, but it does seem to be effective in managing wet sweats. So we often use this in an off-label fashion for management of this particular symptom. And particularly, we would often use this in patients who can't take HRT, such as those who've got a personal history of breast cancer.
Thank you. Next question. If you don't use implants, what do you do for failing to absorb?
So depends what I tend to try some of the different transdermal if that's a preference for that individual. And often switching between different types of gel or moving to a spray can be helpful. And I think also for issues like such as absorption with patches, it's ensuring that it's been put onto sort of dry skin. There is a make of patch which is a bit smaller compared to some of the standard patches, and it has got a slightly different adhesive in it. So sometimes patients I found who've struggled with one type of patch, moving to them that different formulation can be quite helpful. And again, switching between a patch to a spray to a gel can help. Ultimately, some of those patients I do switch on to an oral preparation, but I think that has to be very carefully considered in terms of their risk profile for thrombosis.
Thank you very much. Next question. What are the risks, stroke side effects linked with endometriosis when taking HRT? Are we more at risk of endo returning if we take estrogen?
So I think there is two issues to that. So firstly, the theory is with HRT and endometriosis that as long as it's been given in a combined preparation, the progesterone should provide protection to the impact of the estrogen on the endometriosis. So that's one of the rationales for patients, even when they've had a hysterectomy for as part of endometriosis or management of heavy periods. We would still use combined HRT typically, but I think then it has to be balanced with the long-term impact upon breast tissue in the long term. For those who have not had a hysterectomy, I tend to find that sequential regimes have more of the tendency to exacerbate symptoms because there's that period where they're having unopposed estrogen. So I tend more like to either use with an additional progesterone or use progesterone orally. Or often, I think using a Mirena, I keep saying Mirena, a levonorgestrel intrauterine system can give that continuous progesterone, but with good bleeding control, even in someone who's perimenopausal.
I had a hysterectomy in 2020, but didn't bother with HRT. To see if it helped lasting pain from endo, I'm taking Bijuvi, I think it's pronounced. Not sure it helps with pain, but generally feel a bit better. Estrogen cream that I tried for something else gave me nightmares. Is it okay to take combined after a hysterectomy?
So again, as I've said before, if a hysterectomy is done in the context of endometriosis, I would typically tend to manage people with combined HRT, certainly within the first couple of years anyway, just to reduce that chance of any potential stimulation of any microscopic endometriosis that still remained at the end of surgery.
If you don't tolerate progesterone contraception well, such as low mood, acne, headaches, migraines, fatigue, are you likely to experience the same issues on HRT after surgical menopause?
Yeah, so I think this is one of the things that is quite challenging. So some of the progesterones in HRT are similar to the ones that are used in progesterone-containing contraceptives, but some of them are also slightly different. So I think often I would sort of carefully explore which progesterones it was particularly that were problematic. Was it ones that were levonorgestrel based or northisterone or desogestrel, etc. And often we can, just by switching them to a different preparation, that could be helpful. But the progesterone that I find really useful in the cohort of patients who've been quite progesterone sensitive in the past is something called micronized progesterone or utrogestan, is its other name. So this is molecularly identical to the progesterone that we produce. And I find that patients who've been much more progesterone sensitive with more synthetic progestogens tend to tolerate this much better. It also does have some evidence that seems to help a bit more with sleep quality as well, or sort of certainly onset of sleep. There is some evidence also to suggest that utrogestan might be a bit more breast safe and might be a bit less thrombotic than some of the other progestrogens. But I think we're still lacking in sort of very large studies that are being carefully finished up before we can I don't think we're going to go as far as saying, oh, it's completely breast safe, because it doesn't, but it does appear that perhaps it's a little bit better. But certainly I've had a lot of success with using Utrogestan in that cohort. And the similar group that we would often use that in is patients with severe PMS, who are, particularly progesterone sensitive, who that we've medically induced to menopause, and we're giving them back HRT, but we use Utrogestan as the progesterone component.
Next question. I'm 37 and had a total hysterectomy, including uterus, due to endo, and I've been put onto both estrogen patch and progesterone tablets. Is this the best option?
So I am not going to be able to give kind of individualized advice. I think, again, it has to all be considered individualized care. Broadly speaking, for anybody, certainly, having a surgically induced menopause at the age of 37, then certainly the benefits would be to be on HRT to manage symptoms and for bone protection and cardiovascular protection. So being on HRT is a good thing. To minimize risk from HRT, I would always, to take away the clot risk, I would typically have someone on transdermal estrogen, that'd be that patch, spray, or gel. And then progesterones, as I said, Utrogestan appears to have a slightly better clot risk and progesterone sensitivity, and maybe a bit better for breast tissue. So I would, particularly if someone was very anxious about impact on breast, I would often use that. But equally, I think it has to be an individual's risk profile will vary hugely depending on other factors such as lifestyle, things such as or factors such as BMI, alcohol intake, smoking, and then family history, both of cardiovascular factors and breast cancer risk. So I think it has to be very individualized. But my general rule of thumb would be to have transdermal estrogen. The progesterone, if someone's not progesterone sensitive, then I'll usually manage them with either northistrone or medroxyprogesterone acetate, and if they're progesterone sensitive, use Utrogestan. And I think this question of when to transition to an estrogen only approach, again, has to be individualized, and weighing up potential, perhaps better profile in the long term for the breasts versus the risk of reactivating endometriosis and that theoretical risk of malignant conversion of it. So I think that has to be individualized. And what will be right for one person will not be right for the other. Some patients, they are very anxious about the breast cancer risk, in which case they will have a trial on estrogen only after some time. For others, they prefer to minimize the chance of their endometriosis symptoms recurring, in which case they would prefer to usually stay on a combined approach, certainly until the age of the natural menopause.
Right, next question. Would you recommend HRT for those with endometriosis going through the menopause, or is it better to try to do without the estrogen element as it triggers endometriosis? Is it okay to just use the Mirena coil without the estrogen element?
So in terms of the Mirena coil, that is, the progesterone in that is unlikely to help with any menopausal symptoms. It's a great contraceptive. It's good treatment for many for endometriosis, but it's not going to change the menopausal symptoms. So the strategy to help with menopause symptoms with the best evidence would be giving estrogen, of which we talked about the variety of ways in that could be given. But equally, there is certainly a lot more evidence coming through now of those lifestyle modifications, and particularly the role of CBT to help with not just with some of the cognitive symptoms, but actually for helping with vasomotor symptoms. So I think, again, it's about an individualized approach. But also, I think one of the important factors is also to consider the impact on quality of life from your menopausal symptoms. Now, everyone will experience the menopause differently. And for some patients, some individuals, those symptoms are not necessarily hugely problematic. But for those, if they are debilitating, I think it's reasonable to try some of those lifestyle modifications. But if they're not helping, then we know that the treatment with the best evidence base for it would be HRT. And so that's giving you estradiol in addition to your Mirena coil. Mirena coil is likely to be very protective for endometriosis, particularly at low to moderate doses of estrogen. So I think it's about individualizing your decisions. But I think we also need to recognize that in some patients, menopause symptoms can be hugely debilitating, and therefore it's about exploring what your options are for care.
Thank you. Okay. How does estrogen only gel impact on endometriosis?
So endometriosis, as we've discussed, is typically will be proliferation of endometriosis will be driven by estrogen. So if with estrogen gel, you're still absorbing, a good level of estrogen. So if you're not having progesterone as well, and as you've got residual endometriosis, then there is that risk of, first of all, it will exacerbate your symptoms, so drive proliferation of the endometriosis, but also there is that theoretical risk of malignant transformation. So nobody should be having estrogen-only HRT if they've still got their uterus inside. But if they have had a hysterectomy, I would tend to manage endometriosis patients with combined HRT initially, and then discuss the pros and cons of switching to estrogen only.
What treatment do you advise if a person is progesterone intolerant? Does taking uterogestin vaginally rather than orally help symptoms, or does taking it this way potentially make endometriosis worse?
So there is certainly reports that a lot of patients who use their uterogestin vaginally seem to tolerate some of the GI upset you might get with uterogestin a little bit better. I think it's important to say that it's not licensed as part of HRT in vaginal use. It's licensed vaginally for other factors surrounding fertility, assistance, and some of the rules around miscarriage, but it's not licensed in HRT when given vaginally, although it probably is reasonably equivalent. I think we don't know about the long-term safety. So again, with someone with endometriosis, I think it's balancing out the pros and cons and risks and benefits. I think if their side effects from uterogestin are very debilitating, then it's worth considering a trial of vaginal estrogen. But I think we have to be conscious that we don't necessarily have the evidence base to say it's equally as effective for endometrium and for endometriosis protection.
I had a failed attempt to fit a Mirena coil aged 49, too high a risk of puncturing my uterine wall, I think. What is the alternative? Currently on sequential HRT with patches and 12-day progesterone every 2 weeks, currently having my annual autumnal flare-up of endo, which is pretty dreadful.
In terms of patient options for fitting of intrauterine systems, I suppose it's whether or not you've explored or whether or not someone has explored all of their options. Often sort of contraception clinics who have a complex IUS or an IUD service, which allows them to do insertions with ultrasound guidance, and as well as access to things like paracervical blocks. Locally, we have had some patients that rather than fitting them in clinic, we fitted them at an outpatient hysteroscopy clinic, which often can be effective. But I think in terms of if the intrauterine system is not an approach that someone would want to go down, one option is having them on continuous combined HRT, which might have a higher chance of problematic bleeding if an individual's perimenopausal. The other two approaches that I take is I often add in a continual progesterone, so something like Cerazette, to be taken continuously, which will also have the added benefit of providing effective contraception. One of the other strategies I often deploy is for patients who are perimenopausal, I render them completely menopausal by putting them on a GnRH agonist. So that completely suppresses the ovaries. So there's none of that sort of little fluctuations of their own ovaries. And then that allows to use a continuous combined HRT approach without having a sort of higher rates of unscheduled bleeding as you would see otherwise. Now that's not based on big randomized control trials, but that more related on our experience of patients we're managing that way. But sometimes for someone who's not quite postmenopausal, often that complete suppression and then add back of continuous can give both effective control of symptoms and effective control of bleeding.
What happens to your egg reserve when taking HRT for endometriosis?
So it won't stop what's happening naturally to the decline in egg reserve from changing. So for someone who's on HRT in the same way that it won't prevent you going through the menopause. It'll just mask what the background impact is on your menstrual cycle. Oh, you're on mute.
Yeah. Is it possible to have HRT if you are taking Gynaegest as endometriosis treatment?
Oh, now that's a really good question. I think you can still use it with it, but I'm not 100% sure. We've not had very many patients on Gynaegest. I think I probably would switch them to a more standard progesterone, but I'm not entirely sure of the answer to that. Sorry about that.
From a risk point of view of malignancy, if you've had a hysterectomy but still have ovaries, is estrogen only HRT safe?
So again, it's going back to that question of was the hysterectomy done in the context of endometriosis? And so to reiterate what I said before, so if someone's got a history of endometriosis and had a hysterectomy, I would tend to have them on combined HRT rather than estrogen only, certainly for the first few years, just to minimize that chance of recurrence of symptoms and also that potential risk of malignant conversion. But then it has to be balanced long term of pros and cons of combined versus estrogen only HRT in terms of breast safety.
All right, next question. 6 weeks post-op, full hysterectomy with one ovary remaining, and I'm 34. I'm suffering hot flushes and brain fog with sleeping issues. I was advised to wait 6 months for HRT. Is this correct? As you suggested, I'm at risk of cardiovascular issues now. I had endo and fibroids if this changes my situation.
So this is we know that patients who undergo a hysterectomy, even with conservation of their ovaries, so even if they have both ovaries left behind, will likely undergo the menopause at a slightly earlier age, probably around about 2 to 3 years earlier than someone who had not undergone a hysterectomy. So there's something about doing a hysterectomy that, because part of the collateral blood supply to the ovary comes from the uterus, the blood supply to the ovaries is slightly compromised, and that has an impact on time of menopause. And if one of the ovaries has been removed in addition, so you're left with half your estrogen supply of an ovary that may not necessarily have an entirely normal blood supply anymore, and particularly if surgery has been performed on that ovary in the past, such as removing an ovary, removing a sort of cyst, there is a higher chance of premature ovarian insufficiency. So the way in which we diagnose this now, this has just changed in the new NICE guidelines that are under draft, but I suppose they're still under draft. So whilst I haven't completely digested what the changes in the licensing is, not the license, in the recommendations for monitoring, but certainly in the old NICE guidelines, what we would do is perform an FSH level and repeat that to do 2 of those 6 weeks apart in someone of under the age of 40. And if the FSH is above the level of 30 on those 2 separate occasions, then we would diagnose premature ovarian insufficiency, in which case we would recommend HRT to decrease the risk of cardiovascular disease. And we know patients with endometriosis have a higher risk of cardiovascular disease anyway compared to the general population. So in someone with symptoms of a premature menopause under the age of 40, I would do FSH 6 weeks apart, and if it's elevated, recommend HRT for cardiovascular and bone protection. And then to decrease the clot risk from HRT, or I would use a transdermal estrogen approach, and then consider what progesterone I wanted to use on top of that.
Brilliant. Okay. Right. Last question. Would perimenopausal symptoms after surgery where the uterus was removed but the ovaries were retained be considered natural or surgical menopause? I am currently mid-40s and was informed prior to surgery of increased risk of early menopause.
I think we've pretty much just covered that in the last question. So if the ovaries have not been removed, then that's not a surgical menopause. But as I've outlined, patients undergoing a hysterectomy, even with ovarian conservation, are more likely to have a slightly earlier menopause.
Apologies. Right, so it's 8 o'clock on the dot. So I know we haven't answered all the questions, but as I mentioned earlier, I will copy them and get them sent to our specialist nurse who who answer your queries, and then I will probably email you with those answers. But thank you very much to Dr. Whitaker. I really, really appreciate you coming here today and giving up your time to talk about this really important issue. And thank you everybody who joined us today for giving up your time and joining us as well. As I mentioned,